It's a private sector hospital company. We run 8 hospitals in the country, and 2 of them are mental health care hospitals. One is a day care or day hospital, day surgery hospital, and the others are normal acute care general hospitals where there are all kinds of clinical disciplines that we offer. And I think we're grateful for their sponsorship. The webinars are also accredited with the HPCSA for clinical points, for CPD points. And all attendees who do register by themselves on the HPCSA, on the invitation that we send out, you are asked, as you do your 1 or 2 minute registration, you are asked for your HPCSA registration number, and that's the one that allows HPCSA to automatically, as you attend, those who register and attend, of course. If you register, you don't attend, you don't get points. But if you register and attend, then you get points. We still, unfortunately, still get practitioners using their BHF number, practice number, which doesn't work. So you have to use your HPCSA registration number, whether you're a GP specialist or whatever, allied health professional, use your registration number to do that. And if you, by any chance, you have problems receiving confirmation of your CPD points within 2 to 3 weeks from attending any of our webinars, please do contact us. You can contact us on Clinix, webinars@clinix.co.za. So it's webinars@clinix.co.za. And we will, as our speaker today goes through her presentation, we will mute everyone. So you will not be able to raise your electronic hand and ask a question or make a comment. But at the end of the presentation, you will be given an opportunity to raise your electronic hand. And if you want to put your question or comment orally, you may also, even during the, and we'll send a message to this effect on the chat box. You may send a message on the chat box at any time, even now. The message, if you've got a comment or question related to the topic of the day, or if you have any other comment or question, you may do that on the chat box, and we will attend to it. The speaker will attend to your questions and comments at the end of her presentation. I think we are at this stage. I'm going to tell you who our speaker is. You can see from her slide that is on the screen right now. Our speaker today is none other than Professor Sizulu Moyo, Associate Professor Moyo, MPhD, PhD. Is a public health professional with research experience across various public health disciplines. She is a senior research director in the public health societies and belonging research division at the Human Sciences Research Council, HSRC, leading research on health innovation and well-being. Additionally, she holds an honorary associate professorship at the School of Public Health and Family Medicine at the University of Cape Town. Her work primarily focuses on epidemiology and surveillance of tuberculosis and HIV, and integrates clinical and social aspects of disease, of health, of well-being. Professor Moyo has led several national surveys on TB, on HIV, and on COVID-19 in South Africa, collaborating with national and international stakeholders, and has published numerous scientific articles. She has practiced, of course, as a clinician before, and she began a research career with the South African TB Vaccine Trial Initiative, at the University of Cape Town, and where she got involved in developing capacity for TB vaccine trials in South Africa, conducting preparatory epidemiological studies for TB vaccine trials, and conducting vaccine trials. Before joining the HSRC, Human Sciences Research Council, she worked as an epidemiologist in Medicine Sans Frontiers in Cape Town, in the Cape Town establishment, focusing on drug-resistant tuberculosis. Professor Moyo, I think HSRC, Human Science Research Council, is one of the bodies that we have been in existence for many, many years, actually decades in the country, but many people don't know much about what they do. We all hear about it. It's not in the news, and I think it's not in the news, and we don't read about it a lot, simply because for a good reason, that there's never any drama or scandal like many of our institutions in the country. I won't mention any, and I think they've done so well that they stayed in them. So I'm going to ask you, before you do your presentation, please just to tell us about what the HSRC is and what they do and so on, and then thereafter you can go on and do your presentation, Prof. Thank you very much. Over to you.
Yes, thanks so much, Dr. Kinoshi, and thank you to the organizers for inviting me today. So the HSRC, I think most clinicians may not have heard about the HSRC because it's primarily a humanities research council. It's almost the counterpart of the South African Medical Research Council. However, within that council, we have an element that focuses on public health. And the premise of it really started around 2000, when the then director of the research division, that was called SAHA, wanted to understand HIV in the country. Some of us may remember the days when we did not have adequate data on HIV. So she put together a team that was multidisciplinary, including clinicians and virologists. And that's when this research division that includes an aspect of health was then created at HSRC. And that is how I ended up working at HSRC. In our research division, we focus on public health, really the broad definition of public health. And where people with a medical training background come in is where we're really trying to understand health from a biosocial perspective. The HSRC is also very well known for conducting surveys, various surveys, but the flagship project really, as I mentioned, is around HIV. Most of the HIV work, HIV data that the country has, once we moved away from antenatal surveys, came from the HSRC through the household surveys that have been done since 2002. So we've done up to 6 of them. The last one was done in 2022. We've also done research work on TB. So you would understand that when you are doing research work on such surveys on such conditions, you do need to have people who have some understanding of the clinical aspects so that we can then measure appropriately and report appropriately for the country. So that is what I do. We want to really understand and integrate humanities and health, because our understanding and our view is that health and disease, they don't operate separately, but they are where people live and how people live and where people exist. So that is what I do at HSRC. Just a few things about HSRC. I always think of it as a university because we've got different branches or different divisions. So some divisions look at education. There's a division that looks at democracy. I'm sure you will hear more about it this year because we're going to have our local government elections. So that is in summary about the HSRC. So for me today, the invitation was to speak around tuberculosis. And as you heard from the intro, I've done a lot of work that focuses on surveillance and trying to understand the epidemiology of tuberculosis. And this work has been important in terms of driving some of the thinking around the policy. As you may know, before I go to my slides, South Africa is one of those countries that is got one of the highest burdens of TB. At the same time, it's also blessed in a way because there are a lot of capable scientists across the board, from epidemiologists, from social scientists, right up to the laboratory scientists who have been working on tuberculosis. So we're able to contribute a lot of data, even to WHO. So some of the policies and the things that I'll be sharing today, some of the data was generated from South Africa, or some of the thinking, even if the studies were not done in South Africa, that was generated from South Africa. And this has a direct bearing then on the bedside. How do we then treat, how do we then manage patients who have got tuberculosis? Moving on to my next slide. I'm sure now. Okay. Okay, so when I was asked to speak today, I thought that I would look at this presentation from the premise of the overview of TB in South Africa, looking at this, covering aspects that look at the status, the progress, and the challenges that we have in the country. So this is just the outline of some of the things that I want to talk about. First of all, looking at our context, what is the problem that we are solving for? So understanding the context in which we are operating, and then looking at what we are doing, how are we responding? And I want to talk about screening. I want to talk about diagnosis. I want to talk about treatment. And I also want to spend some time on one element which is post-TB lung disease, which I think has been neglected for a while. I'll also talk about prevention. We know about TB preventive therapy, the new formulations that are now available, but I'll also touch a little bit on vaccination. And something that I think is quite important is the social and the structural drivers, which are also very critical. I'll speak about those. And then I want to speak also around comorbidity in people with TB, and also the phenomenon of asymptomatic TB. And then I'll conclude after that. So just to start off, looking at TB incidence and mortality in South Africa, you would know that because of TB and the burden that it presents in South Africa and globally, is one of those diseases that is significant from a public health perspective. Also significant because TB really is preventable, is also curable. So it's one of those diseases that has been tracked globally by WHO and other transnational bodies in terms of how can we eliminate this totally preventable condition. And you will see the first figure that I have, which will be on your right, the estimated TB incidence. What I want to show you here, what I want to highlight is that between 2010 and 2024, we've seen TB incidence declining in South Africa. So the number of new cases year on year have been declining. And if you look at the dashed line, the 2025 milestone, this comes from the end TB targets, because we're all focused on 2035. That is the aim, that we want to have ended TB by 2035. And there were milestones that were set that we're supposed to reach 2020, in 2025, 2030, and 2035. And for us, in terms of the number of new cases, we managed to reach that milestone. So this is good news for us on this front. However, on the other side of that coin, we've got the estimated number of deaths. And this is the worst outcome that anyone with TB can have, that they will die from tuberculosis. And we can see that we are not where we're supposed to be. So we've got a lot of people who are still dying from TB. And I'll go into some statistics around that. And I'm sure those of you, because I'm no longer in clinical practice, you see these people, and some of you have to certify them when they pass away from tuberculosis. So if we look at the burden, now we understand that our incidence is dropping. That is good news, but we also know that we've got this issue where people are dying from TB. So one has to think about what happens from when a person first gets TB and when they end up as somebody who has passed away from TB, the intervening time. This is what I'll be focusing on for most of the presentation. So understanding the burden, the demographic profile or the epidemiology, this data comes from the Global TB report from 2024, and this data is sent to WHO by our National Department of Health. So the notifications that are done in facilities are very critical because they are then collected and sent to WHO, and this is how we then track the burden benchmarked to other countries in the world. So in 2024, there were an estimated 250,000, just 250,000 people who developed TB as new cases. This translates to about 390 per 100,000 of the population. Now, if you look at those people living with HIV, they formed the majority of that group, 134,000, just about 53%. And then you can see also the drug-resistant TB, about 14,000. Now, what I want to say, you may think 14,000 is not a big number, but I think those of you who have dealt with drug-resistant TB understand just what it means to have drug-resistant TB, the complexity of treatment, the severity of disease, and the likelihood of poor outcomes, and the impact of that on the patient and also on the family. So this is a number that is really too high, and South Africa is one of those countries that has the highest numbers of drug-resistant TB. And then I want to also focus on this part that I've discussed around mortality. This is about 54,000 people dying from TB every year. This number has remained at around this level for over 5 years. So despite our decrease in TB incidence, we're still seeing very poor outcomes. So people continue to die from TB. And I've done a little calculation to just understand what does it mean to have 55,000 people passing away from TB every year. And I think it's about 6 people per hour, if my math is correct, but you can just think about it every day. Think about people passing every day just from tuberculosis that we know is treatable and preventable. Now, if you look at this a chart which looks at the age and sex breakdown of tuberculosis in the country, what I want us to notice is that all age groups are affected. It doesn't matter whether they are children, 0 to 4, they get tuberculosis. The elderly get tuberculosis, but we can see that we've got a bulge right here in the middle. The middle-aged people are the ones who are most affected. What is also important from this graph is that the purple and the orange dots, these represent the number of cases that were seen, that were diagnosed, and that were reported. The green bars represents the cases that are present in the country in each age group, but they are undetected. These people are walking around with TB, probably transmitting tuberculosis, but they've not been detected, they've not been diagnosed, and they are not put on treatment. And we know what that means for TB because it's an airborne infection, and there have been numbers that have been put forward in terms of how many people one person who is infected with TB who is not treated can infect. That's up to 12 people if you look at some of the literature. So this is a telling figure in terms of the number of people living with TB who are not detected, who are not put on treatment. And that also has a bearing on some of the outcomes that we see eventually when they come to the health facilities. I also wanted to look at the key risk factors. Obviously, in South Africa, we know that HIV is quite important. If you just, I took this data also from the Global TB report of 2025. And when you break down the numbers that were submitted to WHO, we can see that HIV is the biggest attributable risk factor in our country. But some of those that maybe we do not talk about as much as we should, look at alcohol use disorders. So when we interact with our patients or when we interact with the people who come to see us, do we even consider the impact of alcohol use disorders on the risk of tuberculosis and on tuberculosis. And this one is also important because it also has a bearing on when somebody has got an alcohol use disorder, they are diagnosed with TB, adherence to treatment becomes affected, retention in care becomes affected, and we'll also see, even if they stay on treatment and they are treated, the risk and the severity of post-TB lung disease is greater, especially in people who abuse alcohol and also those who also smoke. We know smoking for other respiratory conditions, but sometimes in South Africa, we take all our efforts towards HIV and we forget to speak around these other risk factors, which contribute about 36% in terms of the attributable causes. Diabetes has now become widely recognized, and we're speaking more about it than we're speaking around alcohol and smoking, maybe because these are behavioral issues which are not as simple to deal with. And nutrition is also quite important. This is very significant, especially in children. And if you consider the social determinants of health and what is happening right now in our country and other countries, there's been talk around food insecurity. And these are the things that sometimes have got a downstream effect and increased risk of TB in the country. So understanding our context, understanding what the key attributable risk factors are, then how do we respond? Really, I wanted just to use the slide to say that we respond by finding all people who have TB, and we have to find them early. If you think around those green bars that I was speaking about, we must diagnose them correctly. I'll speak about diagnostics and the advances that have happened there. Treat the people who are diagnosed with TB successfully and safely. Those of you who have been in clinical medicine for a very long time will remember that as early as recent as 2010, some of the drugs that were used to treat drug-resistant TB had quite serious side effects. There is one TB advocate who's very well known who lost her hearing because she was diagnosed with drug-resistant TB, and at the time there were injectable drugs whose one side effect was affecting hearing. So this is very important around safety of the regimens that we use. We also want to minimize and manage what happens after somebody has been treated around TB. And I'll speak around this because of the damage that happens to the lungs and also the vicious cycle between the risk factors, lung damage to the lungs, and then the vicious circle that goes related to that. We also want to prevent new cases. I'll speak about TB preventive therapy, as I've mentioned, and also addressing the social determinants, because I think this is one critical low-hanging fruit that we have not always used successfully. Now, to start off, I want to speak around screening. Screening is very, very important to the extent that the WHO has got these modules, these guidelines, which really follow the guideline development protocols. And this was published, I think this one was published in 2022, soon after COVID, around how do we deal with screening so that we can detect as many people who have got TB as possible. Another important point around screening, because once you screen, you can then almost triage people. Those who have got TB go to get treatment. Those who are exposed, then they get TB preventive treatment. And I'll speak about that, which is also something that's very important. So this screening is very important, especially where cases may be or may be missed, as we saw is the case in our country. We may conduct screening using symptoms. We know that symptoms are not very specific. We know that they are not very sensitive. However, they are very useful. They cannot be discarded. The only comment I would make is that they shouldn't be used in isolation. You have to take them within the broader picture of what you are looking at in terms of the person who is presenting. Then we've got chest x-rays. What has happened within the last, I think, past 8 or almost past decade now, is that there have been advances in digital chest x-ray technologies. And while around 2016, WHO had not really recommended digital chest X-ray screening. This is now almost the mainstay. This is very important because it's been shown that it can detect many more people who would otherwise be missed when they have got a TB. And I'll speak about this in terms of the gains and some of the challenges that come with digital chest X-ray screening. So we are moving to digital chest X-ray screening, even with that is AI supported. So AI becomes very critical, and there are now various technologies, various companies that are have got these products, including portable chest X-rays. In South Africa, in the high burden districts, I think there are about 14 in the country. This is from a public sector. There are mobile vans with chest X-rays that have been deployed in high burden areas so that there can be community-based screening, because that has been shown to have value. So system screening is really part of the standard clinical workup. And it can be repeated as often as possible. I'm making this point so that we do not forget, in a country like South Africa, we know the populations that are most at risk. It's something that we can easily do during our consultations. I've already spoken about the digital chest X-ray screening with AI, but you don't need to have AI. You can even do it without AI. What I want to also say is that, screening, especially symptom screening, is not intended to be diagnostic. You do need to then do further evaluations if you want to exclude TB, and also in terms of putting people on TB preventive therapy. Now, this is the point I was making around the value of digital chest X-ray screening. So this is some of the work that I was involved in. Some of you may remember that South Africa did its first TB prevalence survey around 2017, 2019. And such surveys are important because we all know around care seeking that people may have symptoms of TB, but they do not seek care. And so those people are missed. And then programming and how we then target interventions is affected, and we continue having this burden. And with TB, we've got this pool of transmission that we can never break. So this work that we did, and this was based in the community, the cases that we detected that were bacteriologically confirmed, expert and or culture confirmed, more than half of the cases were only detected on chest X-rays. Meaning, if we had only relied on symptoms, we would have missed all these cases. The survey looked at symptoms, if you had symptoms, and then everybody had to undergo a chest X-ray. So some of those people were only asked to submit a sputum specimen for testing because of radiological abnormalities that were consistent with TB. So this is the value of what chest X-ray imaging does in terms of finding TB. In terms of screening, there have been algorithms that have been developed in the country. As you would understand, I speak mainly from a public perspective, but I think these can be adopted in various settings, even in the private sector, because I think most of us know that our patients do move between the public and the private sector. In fact, there was an article that was published, a bit old now, that showed that up to a third of people who have got TB begin their journey in the private sector, and then they move to the public sector. So we can still apply some of these algorithms in the private sector. So within the health facility screening, in the private sector, people presenting to facilities are screened for TB symptoms. But what has been adopted, and I think this is one of the things that has helped us see that trajectory of declining TB incidence in the country, is this targeted universal test and treat approach, where regardless of symptoms, there are certain population groups that are then tested so that we can see if they really have TB, because some of them may not report symptoms. So people who had TB, we know that people who were previously treated for TB, especially within the first 2 years, have got a greater risk of developing TB. We know around people living with HIV, all of us know that. And then close contact, household contact of somebody who is being treated for TB. These are under the TAT, what we call TAT, the Targeted Universal Testing and Treating, they automatically in health facilities, they just get requested to produce sputum samples. And a lot of TB has been detected from those. If then these people do not have this criteria of prior TB, living with HIV or a household contact, then you can then, if there are no symptoms, then you can provide routine care. And if then there is, there are other things that you need to look at, which we'll speak about around TB preventive therapy. This is for health facility screening. This other figure looks at community-based screening. And I know that sometimes we do these campaigns where we are in the community doing health awareness. This is an algorithm that can be followed to try and detect those cases that we saw in those green bars in the second slide that I presented, who may never come to any facility. So this is one algorithm that can be followed. And what is important here, what I just want to highlight is that if there is X-ray facilities, those become very crucial because it almost imitates what I spoke about in the previous slide around that in the TB prevalence survey, more than half of the cases that were bacteriologically confirmed did not report any symptoms, but they were picked up and tested based on radiological findings. So this is one algorithm that can be followed, and you can find this online. It's the SOP TB screening and testing algorithm that was published in 2022. Now, having screened the people, having collected the sputum or the sample that you are using to test, then we come to the diagnostics. South Africa is one of those countries that really adopted molecular diagnostics early. It's called an early adopter. I think once Expect came to the fore, South Africa, I remember, I think that was at one of the international conferences where it was presented, South Africa began rolling out. And I think most of the laboratories in the public sector do have an Expect machine, and we've even diversified from more than one manufacturer. I think it was Cepheid. Now there's also PDMax that is being used. I'm not a microbiologist, but I follow what happens in terms of diagnostics and what the country is procuring. So we do have a range of these molecular tests. And the nucleic acid amplification test, these are really recommended. And in South Africa, GeneXpect is the port of call. We are no longer dealing with smear microscopy as the first port of call. And I do want to say that in a study that we did in 2018, we did this in KZN and we did it in Cape Town. We found that there were some practitioners in the public sector who are still referring for smear microscopy. It's no longer the first port of call. We use it when there's reflex testing, especially when we're considering drug-resistant TB. But as the first port of call, we are really using molecular methods, specifically focusing on molecular methods that help us also detect rifampicin resistance, because this is one of the most difficult types of TB to treat, also very expensive to treat, and we also want to prevent transmission, because once you detect, you can put on treatment, and then we prevent transmission, because we do see transmission of resistant strains as well. And I've made that point because I spoke about the incidence of rifampicin resistant TB in 2020 and 2024, which is 21 per 100,000. It was about 14,000 cases. The main specimen type for pulmonary TB, which is the commonest form of TB, is sputum, but people can expectorate, but we can also use sputum induction. Sputum induction has been widely used in children. We know the issues around getting sputum specimens from children, and the gastric lavages, really, they've been shown to have very poor yield, also very difficult, sometimes even to get. And so there are now safe ways of doing sputum induction. In fact, there was a a guidance on pediatric TB that was published by Department of Health last year, which has got all these, it gives a step-by-step guide on how to conduct sputum induction if you want to get a sputum sample from a child, and in occasional cases also from some adults if you're considering TB. But what we've seen over the past 8 or so years is that tongue swabs have been studied quite a lot, and tongue swabs are now also being used as a specimen type. In children, we also can use stool samples. The expert does have some optimization to detect the bacilli also from stools. However, we would want to get sputum if you can, but this is really being advocated for so that we do not limit testing in children. Children should also be tested so that they can be treated appropriately. And then we know around urine for lateral flow LEM. This is very important for people living with HIV because they may not be able to give you the sputum, but also the sputum, we know that there is postbacillary. And sometimes these are people who have got severe TB. And so where the treatment would really make a difference. And so we should also be using a urine where it's especially in people living with HIV. And this urinary LEM can also be used in outpatient settings. So it's quite a point of care test. And then I want to highlight the things that came out this year. I think it was around World TB Day when WHO announced these 3 developments. And I think some of them are going to be very relevant for South Africa. I think the first 2, because what we've been talking about around is about point of care testing, where you can see your patient, collect the sample, run the test right there at the point of care and initiate treatment. This has been one issue that has been a problem in the public sector, but I also presume in the private sector, because in fact, some of the work that we have done showed that testing for TB was a barrier for some practitioners in the private sector. And we did a study where we actually created pathways to facilitate and link testing of private samples within a public sector laboratory. And that was well received. It was done in KwaZulu-Natal, and we actually detected a lot of TB cases that would have otherwise been detected late or would not have been detected at all. So what has come out in March 2026 is that there is now near point of care nucleic acid amplification test. The initial one, it's called the Plus Life. It's called the Hain Plus Life test, and this is from China. And in terms of the cost, it's actually cheaper versus other molecular tests because you do not really need very complex instruments. I think you can even hold that thing in your hand. Some of you who follow TB would have seen, I think it was Professor Yogan Pillay that most of you would know, who was actually talking about this test. So this can revolutionize testing in the sense that you can screen, collect the sample, and be able to test your patient and get the results very quickly at the point of care. And then the other development was the use of tongue swabs. The tongue swabs in the sense that they were already being used for Expect Ultra, but now there is a new net, the TrueNet MTB Ultima, that I don't think it's available yet in South Africa, but we know that South Africa is very good in terms of bringing in technologies that will support. So this is another development. And then the third one is pooling of sputa. So I think way back when there was pooling of some HIV specimens, but you can actually now pool the sputa, especially when there are resource constraints. This can improve turnaround times. It's not applicable for people living with HIV. It's not applicable for children and also in people at risk of drug-resistant TB because the quality there may be affected. But this is a technology that can then, or an approach that can be used in countries or in settings where these criteria that limit it do not apply. So these are some things that are new that WHO will then update the guidelines. And the point I want to make around this is that these are advances that we're seeing. So there are these giant leaps that are happening now in terms of addressing TB. And some of the work has actually been done in South Africa. I think there is, I think it's Wendy Stevens, who is one of the South African microbiologists in South Africa, who has been really at the forefront of doing some of the work around pooled sputum testing. And this has now gone on to WHO guidelines. And then I'm going to talk about treatment. This is it will be a short mention, very quick, but I've also put in for you the documents that you can go and look at. In terms of the drug regimens, we know that around 2022, WHO came up with new regimens for TB. For adults, the 6-month regimen, but also the 4-month regimen. South Africa has not adopted the 4-month regimen for various reasons in the public sector. Now, I'm not sure what's happening in the private sector, but it has not been adopted for adults in the public sector, but it is available and recommended by WHO. For children, we have moved on to the 4-month regimen, which South Africa has adopted. I think you'd understand the priority around children because we know the issues around treating children, formulations, dosing as children grow up, and also just getting the medicines into our little ones. This has been adopted in South Africa and is actually being rolled out. And you must really, I'm talking about drug sensitive now to start off with. And I've also made some points there around dealing with art. People living with HIV starting art as soon as possible. And in children, also being mindful that we do get other severe forms of TB, especially TB meningitis. We need to be aware of that, but also in adults. And so the use of steroids when you've got cases where you've got these types of TB, including TB pericarditis. And then for drug-resistant TB, as I've been saying, is one of those types of TB that is very difficult to treat. In my opinion, I spent some time working on it at MSF during those days when we were using kanamycin, and it was very difficult, and the outcomes were very poor. They have improved, but they continue to be poor. But the good thing about South Africa is that South Africa has been at the forefront of research and advances in terms of treatment regimens. And so we have seen the changes. For example, now South Africa uses BPAL. And South Africa most of the studies and the clinical trials were conducted in South Africa. And South Africa was an early adopter of these regimens, cutting down the 18-month treatments, which used to be the norm then, injectables, which was the norm then, to 6 months. There was a regimen that was 9 months. So the regimen durations have been declining. 18 months, 9 months, then 6 months. And some people are talking now even of a 4-month one because research is still taking place. But now we are on the 6-month one. And what we've begun to see is that outcomes are improving as people have to take the regimens for a shorter period. These regimens are safer than the ones that were existing in the past, and the side effects are not as severe. It's not to say that there are no adverse effects, but the country is very good at identifying and managing these. And you would know that in South Africa, there is a specialist committee that deals with drug-resistant TB. So my comment here is that when you've got a patient with drug-resistant TB, it does require specialist care. Specialist care can be nurses who have been trained in managing drug-resistant TB, and also doctors who have been specifically trained in managing drug-resistant TB. And there are some cases, as you know, we've got different types of drug-resistant TB. We've got XDR TB, and we've got this resistance to some of the drugs that are within these regimens. And so sometimes there's a need for individualized regimens, and this then needs to be discussed through the clinical committees and through various experts who can then guide us. So I just want to put a note that we really need to seek specialist care when we are dealing with drug-resistant TB in adults and also in children. the child regimens have really been adapted from what is available for adults because there haven't been enough trials. There isn't enough data to create a standardized or to recommend a standardized regimen. So this is a collaborative effort that will be needed if there are children who have got drug-resistant TB. And just to say that children do get drug-resistant TB, it's transmitted sometimes from the people that they live with, especially when care seeking is delayed. The other point I want to mention now, what I want to come to is around the treatment outcomes, and I'll spend a little bit of time around this. So I got these slides, these graphs from the TB recovery plan version 4.0, 2025 to 2026. And what I want to show is that for drug-sensitive TB, we have seen that the treatment success is remaining at about 80%, 83% in 2023. And this is now calculated from the cohort of people who started taking treatment. If you calculate it from all the people who have TB, you would realize that it's lower than this. What I want to highlight is this orange or tan section where we have got all these people who are lost to treatment, lost to follow-up. And then we've got people who are still dying from TB. So this is drug-sensitive TB. These 10% who are lost to follow-up have got potential for mutations, and then they can become drug-resistant TB, which is more difficult to treat. I think I've made my point. But also in terms of transmission, they sustain transmission within our communities. And this is one of the reasons why it becomes difficult to break the back of TB transmission. So these are things that we need to be looking at in terms of how do we retain our patients in care. The other graph is around the drug resistance ones. You can see that treatment success is much lower. We've got more people who are lost to follow up because more drugs, side effects a bit more severe than for drug-sensitive TB. And you can begin to see the mortality proportions are much higher because this is a much more severe form of TB. And this is the one that we really need to prioritize and deal with in the country. I also wanted to look at treatment outcomes by sex and by HIV status. I think we all know that epidemiologically, TB is more frequent in men, and there are many reasons for that. But also, if you look at a drug-sensitive TB treatment success by sex, not much of a difference. The 81% for men, 85% for females, lost to follow-up, mainly in men. And the point I want to make here is that we really need to keep an eye on our men. How do we engage with men when they've got TB and retain them on treatment? I know that it's not only TB, it's across the board. Generally, in HIV, we speak about the same thing. Other conditions, NCD, we speak about the same thing. So I think this is the time when we need to be thinking around how do we engage with men and retain them in care. TB is quite serious as are the other conditions because they can be transmitting TB in their communities where they are. And then we can see that mortality is almost the same. When we look at it by HIV status, the point I want to make here is that you see very poor outcomes amongst those people where the HIV status is unknown because we may not be treating them appropriately. So this speaks to the fact that we need to know the HIV status of our patients so that we can put them on ART if they are supposed to be on ART, or if they are not doing well, then we can take the appropriate action. I think it's gone are the days when we should not know our HIV status or know the HIV status of the people that we're dealing with because it does have an impact on outcomes. Here, I wanted to show TB treatment outcomes for drug-resistant TB by sex. We can see treatment success by sex, not much difference. in terms of males and females, 62 and 63%. Loss to follow up, men again higher, and also we can see mortality as in the outer graph. Now, I said I was going to speak around TB, post-lung TB disease. So we screen for TB, we find the TB, we screen for TB, we find symptoms that are suggestive of TB. We collect the sputum sample or whatever sample we're using. We test it, we diagnose the patient, and we put them on treatment. They stay on treatment and they are treatment success. What is critical is that we need to follow them up after treatment, because there is a growing body of evidence that speaks about lung damage and continuing health concerns after people have been successfully treated for TB. The data suggests that about a third of the people may have post-TB lung disease. Currently in South Africa, we've got a 24-month follow-up. We must see these people in the public sector every 6 months for at least 2 years. Ideally, it should be longer, but we know the public sector cannot always cope. And we know that we're not even doing that very well, but it's something that we need to look at. So how do we even define this post-TB lung disease? It's defined as having evidence of chronic respiratory abnormalities with or without symptoms that are attributable, at least in part, to previous TB. It's very common in people who have had TB. There's a heterogeneity of symptoms, quite a broad range of symptoms that people present with. But really what we see is that the underlying factor is that there's been lung damage, where there's impairment and where there's disability. Spirometry abnormalities are 2 times increased, twice increased in people who have had TB compared to the general population. We've got a more than 10%, have got a more than 50% decline of lung function. You can imagine the impact that it has on the quality of life. There are also other morbidities, cardiac disorder, neurological impairments, psychological challenges. You can imagine if you're always not feeling well, and the quality of life is reduced. And these people tend to die. Mortality is 3 to 6-fold higher compared to the general population, and most of the deaths occur within the first year. We know that we're looking out for recurring TB or a repeat episode of TB within 2 years, but most of these people with post-TB lung disease tend to die within the first year. And where there's been cause of death data, we see that there's cardiovascular disease, there's malignancy, respiratory diseases, things that really align with the fact that they had TB in the past. So this is something that we need to look at. Once we've finished the treatment, let's keep an eye on the patients that we've treated for TB to support them with this other journey that they may have to embark on. I wanted to show this slide because it came from a very interesting paper that was published in 2025, which really looks at the conceptual framework of the potential drivers of TB. The only point I want to make here is that this is a vicious cycle. If you look at the social determinants of health, these are the very same conditions that put people at risk of tuberculosis. But they also are involved in the whole circle of post-TB lung disease. So if we do not deal with TB, we keep on running on this hamster wheel where the causative factors, the determinants lead to poor outcomes, and those poor outcomes then influence the determinants again. So this is quite an interesting paper. I've put the title here. If you want to have a look at it, please have a look at it, because these are some of the things that even as clinicians we need to think about. So apart from giving our medication, apart from doing the medical things, how are we thinking about the broader concept of how our patients or how we are all living in this, in the communities, and all these things that we need to be dealing with. I now want to speak around TB prevention. So we've done screening, we've done diagnosis, we've done treatment. Now, prevention. And I put it this deliberately here because one would say you start with prevention, but now we're at the point where we've got TB circulating. We've got a lot of TB cases, so we have to find them, we have to treat, and then we have to think around prevention. Prevention is a critical pillar of managing and ending TB. Now, TB infection is extremely common. It's estimated that a quarter of the world's population has been exposed to the TB bacilli, and so they are infected. In fact, most of us who have worked in healthcare facilities have breathed in the bacilli, and most of us have contained it. Unless something happens where our immune status is compromised or for whatever reason, then we may then activate to TB. But we've got a lot of people walking around with TB that has got potential to become active. But if we take TB preventive therapy, we can stop that and we can cut that progression, and that's one way in which we can end TB. There was some work that was done, modeling work that was done. It was called a TB prevention investment case that showed the benefits of doing of screening and giving TB preventive therapy. In South Africa, it showed that we could reduce TB episodes by 23%, that we could reduce mortality by 36%, and this is by screening alone, which I spoke about earlier, but that if you add TB preventive therapy, that can increase to 33% in terms of TB episodes prevented, up to 40% of mortality, and then the years of life saved, we could reduce by 42%. So these are massive gains that we can get from screening, which I spoke about, and also using TB preventive therapy. In the public sector, we do have guidelines that were published in 2023 that speak to TB preventive therapy, and they include some significant changes that have to do with the data that has been coming out from research. One, we've got many options for TB preventive therapy. You'll remember that I think before we just had INH only, which was the only mode of TB preventive therapy, and because of resources, it was only prescribed to specific people in the public sector. Maybe in the private sector, it was available to more people. But now the guidelines have expanded the options that are available and also expanded eligibility, because this is one way of breaking the TB burden. So we've got 3HP. You can take for 3 months INH and rifampicin. You can take for 3 months rifampicin and INH. For longer, 6 months INH, or 12 months INH daily. But obviously, we want to encourage shorter regimens so that people can be done with their treatment. And the eligibility, for a very long time, people with HIV, I think this was shown quite early on, that people with HIV benefit from TB preventive therapy. And then we also knew for a long time that close contacts, especially household contacts, we used to circumscribe it to household contacts. But in these guidelines now, it's any person who has got a significant contact is eligible for TB preventive therapy. Pregnant women are eligible, healthcare workers, people in prison, TB survivors, and people with silicosis are eligible for TB preventive therapy. The key thing is that we must exclude active TB first, and that is why the screening then becomes important. So there is an algorithm for the public sector that has that is included in the screening, in the TB prevention guidelines, and this is what we can use. This is the general screening algorithm, but there are specific algorithms for children and also for people living with HIV. The one thing I want to mention is that we for TB infection, we know that there are tests. You can do a tuberculosis skin test. Nowadays, you can do the eGRAS. these are very useful, but they are not a requirement to put somebody onto TB preventive therapy if they're eligible for it and you have excluded active TB, because we know of the benefits. So this was one thing that was a hindrance in the public sector, but it's now been very clear that yes, these are very useful. They confirm infection, but they do not have to become a barrier to TBT for those who are eligible to it, who are eligible for it. I now want to move on to speak around another mode of prevention, which is TB vaccination. We know about BCG, which is now about 100 years old. In fact, when I was working at the South African TB Vaccine Initiative, setting up the TB vaccine trial infrastructure, our first study to set up the infrastructure looked at the route of administration of BCG, percutaneous administration and intradermal administration, whether you could get different levels of immunity of immune responses. So this vaccine, which is now 100 years old, what we know is that it is not very effective, especially in adolescents and children. If you look at the literature, in adolescents and adults, I mean, if you look at the literature, you will see that efficacy ranges from no efficacy at all. I think some of them is even negative, up to 80%. And what has been said is because that's different types of studies that were done, different strains, different variations of the vaccine. If you look at the types of vaccines that were given in the early years. But what is also clear is that it does protect, especially children, from severe forms of TB. So miliary TB meningitis, that is why we still give it to children. So it must continue. I know that in the journey to new TB vaccines, other countries have tried to introduce a second dose of BCG vaccination, but it hasn't really shown much efficacy. What we've seen is that immunity from BCG tends to wane over time. By the time people reach adolescence, that immunity has dropped to about 36%, some papers say. But from what we are seeing in our country, we know that by the time you reach that middle age, there seems to be no protection at all. That is why now there are efforts to look at a new vaccine that is effective across all age groups, but particularly in adults and adolescents, because at least children have got the BCG that will protect them for a while. But then once you hit adolescence and adulthood, then there is no protection. And so I've shown you, you can go to the WHO website. There's the TB vaccine pipeline is quite rich, but we know that a lot of them do fail in the different phases. I've highlighted the ones where South Africa, which we've got work, which is being undertaken in South Africa. We've got the M72, which I think is the one that is leading at the moment. It's been shown to have about 50% efficacy, and modeling shows that even with 50% efficacy, you would have a lot of impact. And so that's the one that's being done in the country. We also have MTB-VAC, that's also being undertaken in the country. And South Africa as a leader is already looking at the policy imperatives that would be required if we're to introduce a new TB vaccine. And some of you would have known that last year there was an important workshop on TB vaccine preparedness, which was hosted by WHO and National Department of Health. And this covered the science, the basic science, the immunology, but also the people aspect and the delivery aspect. Where would it even fit? How would we even fit it within EPI? And also looking at some of the lessons that we learned from vaccine hesitancy and anti-vaccination rhetoric during the COVID-19 pandemic. I just want to check that I've got time. Please let me know. Maybe I've spoken too much, then I can truncate my talk.
No, you can still continue and finish your presentation, Prof. You are doing well. Thanks.
Okay. I want to speak about something that I think may be deprioritized, but which I think is very important. Maybe important also because I work a lot with social scientists. the social and structural determinants of TB. And I see this as a low-hanging fruit, which can really assist us in dealing with the TB burden. We know from evidence that in Europe, TB began to decline before there was chemotherapy. And in fact, there's been a paper that has been published looking at the diverging TB burdens in Europe and Cape Town from the pre-chemotherapy era up to when HIV then became an issue in the country. And really, these reductions were attributed to things that have to do with the social and structural determinants. Improved living standards, people were less crowded, improved nutrition. And it was quite interesting because we knew this from that time, but recently, I think it was in 2023, there was this paper that came from India that showed that supplementing nutrition could actually lead to a decline in TB incidence. And this paper was heralded as a breakthrough, as an innovation, but we're just learning things that we knew already, but we're not applying for various reasons. The other measures were public health measures, such as the ones that we are already implementing. So the point I want to make is that structural interventions are critical, but they tend to be difficult because maybe they require evidence beyond the health sector. But these are things that we need to look at, especially given where we are in the trajectory of TB and also around the funding and all the other issues that are in the health and care space. WHO itself has recognized this, and they've developed a framework that can bring different stakeholders together in terms of trying to think about TB. So I mentioned this paper around the impact of nutrition, but there's also another paper that came that was written this year around this tuberculosis genetic environment that really looks at the structural TB within this social context, looking at the structural drivers at various levels. I think it was quite an interesting read, and you can read it if you have time. The one other point I want to speak about is around the community knowledge about TB. So what are the community issues? What do we say to each other around TB or patients and issues around stigma? And this comes from some work that we did in our HIV surveys where people know around transmission about TB, but what was striking around people living with TB and living with HIV and those living without HIV is that people didn't realize that you can die from TB. You know, TB is seen as this condition that the worst outcome of death, people don't always think about it, but it's something that maybe we need to really speak about, not to scare people, but so that people understand that there is this worst outcome that can actually come from having a TB if we don't follow the correct ways of managing it. And then the other point that speaks to screening, seeking care, remaining on treatment is the issue of stigma. We found that there is a lot of stigma around people who have TB. This data comes from people living with HIV where asked about their experiences with stigma when they were diagnosed with TB. So this is to say that knowledge doesn't always follow behavior doesn't always follow knowledge. So as healthcare practitioners, we do have, I think a responsibility to continue the messaging. Apart from giving chemotherapy and the clinical things, there are these low-hanging fruits that can also assist us in dealing with HIV. And then I just wanted to say that we must consider comorbidities, especially if you look at where the bulk of our TB burden is, this middle age group and the older group. Obviously, HIV is a key one, but there are other comorbidities that we need to think about. In the youth, I think we need to think about mental health conditions because they also affect care seeking. They affect retention on treatment and adherence to treatment. So let's think about those ones. And in terms of thinking around how they affect care seeking, these ratios just show us the population groups where TB was most likely to be missed. And part of this has to do with care seeking and also accepting that I may have tuberculosis. Finally, I want to speak around asymptomatic TB. because this is one thing that is now having increased public health significance. And we're picking it up and it's becoming more important because of early emphasis on earlier detection and earlier diagnosis. However, it does raise important questions. These are people who have got chest X-ray abnormalities, bacteriologically confirmed disease, but they report no symptoms. In my mind, I think there are two groups. There are people who trivialize symptoms. Oh, I'm coughing. Oh, I've got these night sweats. Oh, I've got a fever, but I'm okay. I'm continue. They trivialize the symptoms. So those may not really be asymptomatic TB. But there are some people who really do not report any symptoms. So how do we even deal with those? So these are the important questions and the implications. There's also uncertainty around the outcomes. We know that the state of TB from infection to active disease, especially at the beginnings, a number of infections resolve spontaneously. If we're not doing this screening and early detection, where some of these are going to resolve spontaneously without even being known that they were there, these are questions. So what proportion then progresses to severe disease? And does it even matter for transmission? This question may already have been answered. I think that data has shown that it does matter for transmission. And then in terms of treatment, at the moment, there is no distinction between a bacteriologically confirmed case of TB with symptoms or no symptoms. Treatment is the same, but this is an area of active research, and WHO will update the guidelines, and generally South Africa follows most of what WHO says. And because of this phenomenon, there have now been some definitions so that when we do research and when we report, reporting and communication is standardized. And these are the definitions that you can find on the WHO website. So I want to conclude by saying that, we've made significant progress in addressing TB. We saw our incidence rate, but we've got a lot of people who are dying from TB. Dying from TB because they are not being seen early enough. And you know what happens when there's severe TB. It's very difficult to deal with, and also drug-resistant TB. We've made significant progress in screening, diagnostic, treatment, and prevention. And as I've said, South Africa, we are leading the pack. We've got effective tools, but we don't always fully implement them. So to close the remaining gaps, I think we can do better with what we have, and we need to work collaboratively together across the board. And the TB vaccine, the new TB vaccine, really is one of the most topical things that is spoken about now, and it will definitely have a significant change in the elimination trajectory. And that is the end of my presentation. Thank you very much.
Thank you very much, Prof. Moyo. I think I see a lot of applause across the screen. This was a wonderful lecture, a refresher, but also a lot of new information that not all of us had. And I think we are glad that we invited you. We might have to invite you again, I think, on this topic of tuberculosis. We've been hearing about tuberculosis since we were born. I think all of us in this country. So it's been endemic in our country all these decades and decades and decades, if not centuries, maybe. And I think it's one disease that has outlasted all the others that we have managed to conquer. I know you said that the incidence of tuberculosis is decreasing since 2010, and that we aim to eradicate tuberculosis in this country by 2035, if I heard you correctly. That's only 9 years from now. But I think from what you told us, there's still a lot of work that we need to do as a population, as healthcare professionals. I think this was wonderful, and I think there were over 601 people logged in today. I think all of them, I think, must have gained a lot. There are quite a number of questions, but maybe let me deal with a number of messages that I've seen in the chat box that people put in they type their MP numbers in, And I just want to say that the HPCSA receive our registration. So when you register to receive a Zoom link, automatically that registration will go to the HPCSA directly, will be sent by our systems to HPCSA, and you immediately, well, you're on the waiting list. Once you attend as well, you register, you attend, then you will receive your CPD points within 2 to 3 weeks, as I said earlier, automatically. So you don't have to do anything. But if you put them in your numbers in the chat box, I think we'll have to see those who have not registered and got the Zoom link secondhand from someone who had registered. I'll have to see how we deal with that one, whether we can, I'll ask our technical staff, whether we are able to assist you if you put your registration number only in the chat box. But I think the sure way is to make sure that you register before the webinar. I know that I got a number of messages that this week we sent them quite late to members via WhatsApp and so on. But I think our system is meant to send emails a number of days before the webinar. Emails, you receive an email invitation if you are a previous attendee. So you should get an email. So please check your emails. I know as doctors we are always so busy, we only see your emails a week or two down the line. But all of us who've attended before would normally get email invitations because when you register, you give us your email address. You also give us your HPCSA registration number, your MP number. That's what we need. But we will continue to send WhatsApp notifications via the many doctor WhatsApp groups that we have, and we'll try to send them earlier next time. But I think let's go to the questions. I think we've got, Prof, we have a question from Dr. Zuki Swapinini, who says, is gene expert also used for diagnosis of drug-sensitive tuberculosis? Maybe you can start with that one.
Yes, I hope it's the doctor's opinion whom I may know. Yes, so it is used for drug-sensitive TB. The advantage is that it will pick up rifampicin resistance as well. That is why it's the mainstay, because then you do not miss rifampicin resistance, so you can immediately then know which way to go in terms of treatment. Even if for drug-resistant TB, there is that second sample for reflex testing.
Okay. Yeah, your voice was down a little bit, but towards the end of your response, we could hear you clearly. Dr. Tabiso Moledi says, how often do other types of Mycobacterium species complicate the diagnosis of Mycobacterium tuberculosis?
I do not have that statistic right now, but with Gene Expert, we are targeting, because it's a molecular diagnostic, we're targeting the particular gene area of MTB proper, not the NTM. That is why when you when you use the molecular diagnostics, because it's a molecular diagnostic, the genetic area, I don't remember the name now of the specific genetic area for MTB, not NTM, is the one that's targeted. People may have secondary infections with NTM, but when we use molecular diagnostics, then we definitely are picking up MTB. But I don't have that number at the top of my head right now in terms of the proportions. I also have NTM.
Thank you very much, Prof. Yeah, I think Prof. Zach Koto, who most of us should know, Prof. Koto says, thank you very much, Prof. Moyo, for a great talk. Can you comment on the duration of therapy of extrapulmonary tuberculosis? Is it still 9 months, or it depends? I suppose it depends on the condition of the clinical condition of the patient or on some other measure that you use? The duration of
Yes,
therapy for extrapulmonary tuberculosis, yeah?
yes. From my knowledge, it is still 9 months. But also obviously because it's not your typical pulmonary TB, you also have to monitor your patient. As far as I know, it is still 9 months. It has not changed because it's extrapulmonary.
Okay. And he also says for HIV positive patients, the presence of splenic microabscesses in a patient with acute abdomen are considered diagnostic of abdominal tuberculosis. Your comment, please, if you could comment on the presence of splenic microabscesses in a patient with acute abdomen.
To have a definitive diagnosis of TB, you must have the bacilli, right? So if you grow the bacilli from those abscesses, then definitely you would have TB. But I would not say that you've got TB if you have not grown the bacilli. So I think it will be important to be clear around what organism are you treating. Are you actually growing the bacilli? Did you detect the bacilli? Not growing, did you detect it from testing? Then you say that would be TB.
Yeah, if Prof. Koto, if you want to come in on that one, I'm not sure whether you are answered. If you want to come in, please indicate. You can unmute yourself and make your comments or questions orally if you like.
Yeah, no, thank you very much, Dr. Kinesh. Thanks, Professor Moyo. Excellent talk. We really enjoyed that. Yeah, I think this is one of the things that, in the surgical field, we come across quite often. Patients come with who are HIV positive. They have, acute abdomen, tender abdomen, and then cross-sectional images show macroabscesses. So what do we usually teach? And I agree with you that the final arbiter is to, demonstrate, the acid-fast bacilli. The challenge is, you need to start treatment. These patients often have acute abdomen, and surgery often would not be the appropriate thing to do in this sort of thing. So we start TB treatment. So this is one of the things that there's quite a very high positive correlation between microabscesses in a patient with HIV positive and TB. So I think the key here is that it helps us avoid unnecessary operation. And many of these patients often they do respond to anti-TB treatment and avoiding unnecessary surgery. I just want to maybe your views on this. Thank you very much.
Okay, great. Prof. Koto. Any further comments from you, Prof. Moyo?
Yes, thanks, Prof. Koto, and thanks for the work that you do because you see the worst, and that is one of the causes of mortality, late presentation, right, for TB and HIV, and you're seeing these complications. The one thing that can be of assistance is the urinary lamp. So you can use urinary lamp, that would definitely give you a diagnosis, and so you can be sure around what you are treating. So it's recommended, especially for these acutely ill patients, HIV positive. You won't be able to get a sputum from them, but you can take the urine and you can use urinary lamp.
Okay. Let's go to Professor Dirk Du Plessis. Professor Dirk Du Plessis is it's a cardiothoracic surgeon of note. He's got some comments, and maybe let me read through them for those who are not seeing the comments in the chat box. Not all of us are able to so alert, but I'll read through them and then you can make your comment, Prof. Moyo. Prof. Du Plessis said some points from my side. Agree that digital AI-assisted chest X-ray is great. Detection at clinic level is very poor, he says. And then 3, he says, in a country with a high burden of TB, the molecular diagnostics is not very specific. It does work very well in countries with, it does work very well in countries with a low burden, and we have a high burden. So what he's saying is that the molecular diagnostics may not be very specific. His 4th point is prevention remains the ultimate solution, and we agree. And then lastly, he says, pardon my mildly cynical comments. I work with the West End stage complicated cases. Well, what would be your comment, Prof. Moyo?
The digital check structure with AI in a clinic setting, yes, I do agree. If you remember the screening algorithms that I showed you, we don't even have the chest X-ray imaging in a health facility setting. So in that setting, you may not need it. So I do agree with that. On the molecular diagnostics, I think because of the targeted gene area, it becomes very useful because then you can detect the TB because you are, and I forget in the gene area now, I think it's MPOL, it's not MPOL 72, but because you're targeting that particular genetic area of the bacilli, then you can really pick it up. What we've seen since the introduction of experts, I think we have increased our detection rates, our diagnostic rates, and we can just look at the various TB reports. That's what I would say because of that particular, of the specificity in terms of being able to detect that particular genetic area of the bacilli. Forget now. Yes, and I do agree. Prevention. It's not always prioritized. You know, we go to the other things, treatment and so forth, but I do agree 100% prevention. And I think that is why there's all this interest in this vaccine. It's not the only way to prevent, but I think that is why there's a lot of emphasis on a new TB vaccine that could really prevent TB. I mean, I was reflecting on this and thinking about lenacapavir now for HIV. I mean, you did say that TB has been with us since time immemorial, and look where we are. And look where HIV is now. They've got a preventive vaccine. Or there's a preventive vaccine, but TB, we're still dealing with a vaccine that's 100 years old, and we know the efficacy is not as what we would want it to be. That would be my comment. Thank you to the Prof. I think you're muted, Doctor.
No, thank you very much. Now, I was saying we still need you a lot in the clinical field. I know you're doing a lot of research, which is great, the SSRC. But I think your knowledge is amazing. Thank you very much. I think I agree with the many comments in the chat box and on the screen. But yes, Dr. Makale Motlante, he says most of us are glued up in, not glued up in TB in the private sector. TB with reinfections in prisons are a crisis with severe post-TB lung complications due to overcrowding. What would be your comment then?
Yeah.
Our prisons.
Oh, yeah, that's a difficult one. I know that there were prison programs. I was also involved, I think 2 years ago, in writing our South African application for Global Fund support for the TB program. And one of the areas that was included was capacitating the prison system in terms of screening, detecting, and then putting on treatment. But I think it borders on the structural issues, right? If there's overcrowding, how do you even deal with transmission unless you can have a preventive approach? So it would mean identifying those who have got TB early enough, which I think there are efforts to do that, partly through the support of Global Fund and through the correctional facility health services, and then making sure that people stay on treatment and then introducing prevention. But if you cannot deal with the structural issue of overcrowding and detecting them early enough, I think that will be a problem. So people in correctional facilities are known as a high risk population. And when you read the documentation around TB, there are particular ways in which they should be addressed. And I think that's a gap where more resources and more, both human and otherwise, are required. But I do agree with the with a colleague that it's an area that requires more effort around the health part, but also the structural issues that pertain to correctional facilities.
Thank you very much, Prof. I see the number of questions increasing, so we might have to chop them, but I'll choose. There's a question from Dr. Muhuddin Khan. Dr. Khan has put on the screen a clinical picture, I suppose, of a patient, but I can't understand what the question is. Maybe, Dr. Khan, you may unmute yourself and tell us what this clinical picture is of acute febrile episodes, mild tachycardia, asymptomatic, previously no weight loss, hemoptysis, normal FBC is ESR4, and so on. Do you want to put your question orally, Dr. Khan? You can go ahead if you can. Dr. Khan, you can go ahead. All right, I can see that Dr. Khan is trying. Are you able to assist Tolakele in the background?
Yes, Dr. Kinoshi. I have unmuted everyone, so Dr. Khan does have permission to speak.
Yeah. Otherwise, you can come back to it. If you can raise your hand, Dr. Khan, and we'll come back to you, right? Thank you. Let me go. Dr. Mweketi Mati. Dr. Mweketi Mati, whom I know quite well. Dr. Mati, good evening. Great. He says, great presentation, Prof. I noticed you did not mention ultrasound abdomen to screen for abdominal TB. What would be your comment, Prof? Ultrasound?
Yes, thank you. I think because I'm no longer fully in the clinical sector and in clinical work, and we kind of from a policy perspective, no, it's one of the it's recommended, it can be included. So I just did not go into it, but I do agree that it's one of those that you can also use for a TB abdomen. I do agree. I just did not mention it.
Okay, great. Just going through the messages. Someone, I think it's Dr. Higgins asking, will the recording be made available? Tolakele, you want to answer that one? Normally, we ask the speaker whether the speaker would agree that we send a copy of a presentation in a PDF form to those who ask for it. So we don't send to all attendees, 600 plus people, but if those who request, so we normally ask the speaker. So you may request, you can send us a request on email, webinars@clinix.co.za, webinars@clinix.co.za, and we'll come back to you, Dr. Higgins, but some of them are available on YouTube as well. Tolakele, you would like to comment on that?
Yes, correct, Dr. Kinoshi. We do upload our videos on our YouTube page. The YouTube page is Clinix Health Group in full name. Thank you.
All right, yeah. Clinix Health Group on YouTube. Dr. Pinini comes back and says, regarding TB guidelines, is there a system in the private sector that monitors use of guidelines? Is there a system that collects TB data in the private sector? You want to respond to that, Prof?
I think the members here would be better placed to respond. To my knowledge, in the work that I've done, as I said, we did a study where we collaborated with the private sector. And this was done in Durban. We actually had to get the patients notified in a particular public health facility, because I understand that you have to be linked to tier so that there can be notification. So I'm not aware of a system, especially for notification in the private sector. And in terms of the guidelines, I'm also my understanding is that the guidelines that are produced by the National Department of Health would apply everywhere in the country. Obviously, there may be capacity for other therapies in the private sector that are not available in the public sector, some of which may be aligned to what happens maybe in the abroad, in the more advanced economies. But our guidelines that are developed by Department of Health are really benchmarked on WHO standards, and so they are really good to go, and they would be applicable in the private sector. I recall that we actually had a webinar with Summer when I was doing when I were working on the project that I mentioned, where we actually shared the guidelines with the GPs who were participating in that project and the networks in the area. I hope that answers Dr. Penini.
Yeah, I think Dr. Penini, I used to work in the National Department of Health for many years, so maybe she can also find out from the National Department. But it's a very important question, because if we fight TB in the public sector, but we ignore the private sector, it would not work, and the disease would just continue to escalate. But I know that TB is still a notifiable disease, so and the private sector also has got an obligation to notify the department of each and every TB case that they get, they come across. So all private sector establishments, hospitals, GPs, specialists should be complying with the law in this case. Thank you very much, Dr. Penini, for the question. I think Dr. Mati comes back and says, the challenge is I've seen multiple patients newly diagnosed with HIV with high CD4 count, and so urine LAM not useful. The only diagnostic that came back positive was splenic microabscesses in abdominal ultrasound. But I think Prof. Moyo has responded to that question, and he says, although she left it out, she is aware that abdominal ultrasound is important. Let's go to Dr. Mukhali, Dan Mukhali. He says, I stand to be corrected, but I was made to understand that lenacapavir is not a vaccine, but a long-acting antiretroviral agent. It does not induce antibody formation. Very interesting. Prof, would you like to comment on that?
Yes, the doctor is correct. I think it's the use of the terms. It's an injection. It's an injectable antiretroviral that blocks the entry of the virus and blocks the multiplication of the virus. So it's an injectable. It's not a vaccine. It doesn't induce antibodies. That is why you have to take it twice a year. So that is correct. And so I retract the term vaccine for lenacapavir. It was not the correct term to be used.
Yeah, I think it's used everywhere. Even the National Department of Health, I've heard them use that term. And I think that's why the media and everyone thinks that. And once you say it's a vaccine, I think it should be explained that it doesn't induce long-lasting resistance to HIV, and that it has to be repeated. I think that's a very important question and response. Thanks very much. Dr. Kayinza, is a physician. Good evening, Dr. Kayinza. She says, when do we send patients back to their homes once we have diagnosed and started treatment so that the family and the community is safe? So when, after treatment, how long will they remain infective? when can we send them back?
The standard has been about 2 weeks that they are non-infectious, but it can even be less than that, especially if they are taking their medication properly. So within about 2 weeks, they should be non-infectious. That's the standard that is generally been used. But we also know that a lot of patients are treated as outpatients. So there is the what you may call it, the non-pharmaceutical measures that people need to take in terms of preventing transmission. And just linked to that, the contact investigation is very, very critical once there is an index TB case, so that we can then put those people onto TB preventive therapy once active TB has been excluded.
Yeah, I see Dr. Opaitete agrees with you. Is also says 2 weeks in the chat. Thanks, Doc. There's a comment from Dr. Umpumeti Dingoko. He says before the notification was done in the notification books, the doctor will fill in a tier of slip will be given to the patient upon discharge to take to the clinic for registration and notification. Now the private hospital only notify the patient via NMC system. I'm not sure what the NMC system is. That is also used by government. So I think he was responding to the issue of notifications in the private sector. But someone maybe can enlighten some of us what NMC system is, unless if Dr. Edingoko would like to tell us orally. You can just unmute yourself let us know. I see Dr. Kunene, Pindile Kunene also says the same. So it looks it's a term that is currently used a lot in the private sector. You want to comment on that, Prof. Prof. Moyo? I think that was our last question actually, or comments.
Yes, I forget the name NMC. It's actually on the NICD website, but I am aware of that, and I think it became. I sense that it was kind of strengthened during the COVID times when there was this close collaboration between the private and the public sector. So that is a way. I forget the term now. Maybe the colleagues can remember what it stands for, but I'm aware.
Yeah.
NMC, and I think the issue is everybody using it? The big groups, hospital groups, yes, I understand, but are we all using it in our private facilities? Because we do see patients with TB as well.
Yeah,
Okay.
I see Dr. Dimakatsun because he has taken us out of the misery. He says it's notifiable medical condition. Yeah, notifiable medical condition, NMC. Thank you very much. I think we've attended to. If I missed any of your comments or questions, please pardon me. But we will go through them, and if there are any questions that are still in the chat box that have not been responded to, we may send them to Prof. Moyo, and they may respond directly to you. Thank you very much. I think at this stage, I'm going to hand over to the Chief Medical Officer in Clinix, Dr. Baden Shinas, to do the thanking of everyone and closing remarks. Dr. Shinas, I think your time to shine.
Professor. Professor Moyo, thank you very much for this evening. I know some time back when initially I contacted Professor Salome Maswime, who basically was part of the founding of the South African Clinician Scientist Society. What she did is she came forward and she said to me that she's going to ensure that the experts that speak on various topics actually do not just speak from the perspective of a clinical presentation, but also actually utilizing research and clinical data and evidence. And so my colleagues that are on the line with me this evening will certainly join in And thanking you so very much, Professor Moyo, for the fact that you do research. It's not just a matter of reading textbooks, you investigate, you're finding out, and not only that, you are actually helping us get better. You are teaching us, and there are always new evidences. And I think so many times we are caught up in practice and the way that we do and what we learn in our own habits. And then we have to appreciate colleagues such as yourselves that are going there and helping us reach new frontiers in every aspect of healthcare. So we want to congratulate you for your daily commitment, your time, your effort to your patients, and also to your colleagues that are able to receive this knowledge and apply it to our patients that we are working with. So thank you very much for that, Professor Moyo. It actually, when you sent me the topic initially, where you said you wanted to talk about TB, I was reminded of a saying that was attributed to Mother Teresa, who said that the biggest disease today is not leprosy or tuberculosis, but rather the feeling of being unwanted. And so thank you so very much while you consider that. The colleagues that are still on our line, it's truly remarkable and really unselfish of you to always remain to the very end of the presentation, not only once the speaker has completed the presentation, but the fact that you stay for the questions, the answers, participating, asking questions. It is so motivating, especially for the speaker to feel appreciated, right? And thank you so much for the applause, the hearts. They always continue to go up, and it's really encouraging. And this is what allows our colleagues to come and present. And it's challenging to be here because behind the scenes there, we know that most of you are experts in your respective fields, and it can be somewhat intimidating. And yet our colleagues come forward and they prepare these presentations. So thanks to you. The presentations that are presented by the Clinix Health Group and sponsored will continue every Thursday. Next week, we have a exhilarating and thrilling speaker that will be coming forward from one of our colleagues. I'm not going to surprise the orthopedic field, so I look forward to seeing you next week. Then for the technical side of things, I know that we're back now with Zoom, so it's working much better, and we really appreciate your patience the previous 2 weeks or so. And so thank you very much for your understanding during that time. Again, I think everything is working much better now, more efficient. And I hope that you have a very blessed evening. Thank you to Tolakele and the team in the background. And as I mentioned, Dr. Kinoshi, welcome back. Spent most of the day with you today. But yeah, and now we're having the evening together. So thank you, everyone. Those that are traveling, travel home safely. Professor Moyo, thank your family for us and that they lent to us for a few hours this evening. Thank you, everyone. Have a blessed night. Thank you.